So this lesson is broken up into three sections, right? There's assessment, diagnosis, and treatment. When we talk about a sequence, we go in that particular order. Because with a clinical assessment, we're trying to determine whether an individual meets the criteria for a particular mental health condition. Sometimes the results suggest that there is no diagnosis, right? There are times when a diagnosis is not warranted. And those individuals will report back what our findings were. And hey, I diagnose you with quote unquote normal, right? Whatever normal means, right? But there are other individuals who, based on their performance on any number of clinical assessments, and we'll go through it, might meet the criteria for a particular diagnosis, whether it's anxiety or depression, whether it's eating disorders, bipolar disorder. So we could come to a diagnosis. And then the diagnosis is very important because it informs the treatment. And the treatment is how we address the symptoms related to the diagnosis. So notice we're not automatically taking everyone into treatment and say, yeah, we're going to work with you if there's nothing wrong with you. That would be unethical to bill insurance or charge a person to see you and there's nothing wrong with them. And the diagnosis, in addition to it being a framework for conceptualizing how you want to approach treatment, it also allows other professionals to have a shared language. So if I were to say panic disorder, right? When I use that diagnosis, my colleagues are going to understand what I mean by the term panic disorder, right? Now, we will also have to note that there are specifiers. So I might have to say whether it's with agoraphobia or without agoraphobia. We also have, agoraphobia as a potential standalone diagnosis. All right, but we'll get there. So that is what we mean. If I use the language major depressive disorder, my colleagues are going to know what major depressive disorder is. Now, I would want to specify whether it's with seasonal onset, if we're dealing with seasonal affective disorder, or if I wanted to specify with postpartum onset, so postpartum depression, we might specify, and there are a whole host of other specifiers, but I'm giving you a little bit of the flavor. So when we do our assessment, it can lead to a diagnosis, and the diagnosis informs the treatment, as well as allows for a common or shared language between professionals. So let's start with clinical assessment, right? So in general, an assessment is designed to collect information that we believe is relevant to answering a question or reaching a conclusion. When we use the language clinical assessment, now we're trying to figure out if there is a clinical diagnosis that is going on and how a person might be behaving, perhaps normally or abnormally, and why they might be doing that. And then we could also do an assessment on the effectiveness of the interventions or response to interventions. Now, clinical assessment comes in many forms, as you will see as I progress in this video. We have clinical interviews, psychological tests, observational strategies. There's a whole host of ways that we can approach this. Now, what approach we use depends on several things. The first thing it depends on is the clinician's theoretical orientation. Projective tests, as we will talk about, come more out of the psychoanalytic perspective. So if you are psychoanalytically inclined, you're going to probably be more likely to use a projective test as part of your clinical assessment. Whereas a cognitive behavioral therapist will be more likely to use rating scales or inventories as part of their assessment. So your theoretical orientation matters. I will also say what you're competent in matters. So a clinician is going to use an assessment that they know how to administer. And then I would also say the referral question matters. So yes, it is true that the tools you use in assessment depends on theoretical orientation, but that is not the only thing it depends on. It depends on your competencies. And from an ethics point of view, we are only allowed to administer instruments that we are competent in administering. And as I said, whatever the referral question is, that's going to inform the type of tools you use. So let's start with clinical interviews. When we say clinical interviews, typically we're meeting face to face, although I will tell you that post-COVID, there's a lot more clinical interviewing and the full course of therapy happening virtually. But clinical interviewing would typically occur face to face, and that would be your first contact between the client and the therapist. And you would take a detailed history, or what we call a psychosocial, on a client. We would focus on things like one's home life, educational attainment and functioning, work history, substance use history, family history, developmental history, legal history, and so forth, right? So that's not all of the areas we would focus on, but we're trying to get a complete picture of who the client is. Now, clinical interviews can occur in many forms. It can be a fully structured interview where all of your questions are identical for everyone. The problem with that is that if you do that, you might miss some of the important follow-up questions. We also have something called an unstructured clinical interview, where it's conversational and free-flowing, and it's tailored to the individual. But most of us in practice use what's called a semi-structured interview process. And when we say semi-structured, there are certain questions we're going to ask everybody, but the follow-up questions are dependent on your answer. So if I were to ask a client related to a substance use history, have you ever tried drugs and alcohol? And they say no, there's no need to follow up beyond that. You can move to the next area of your assessment. But if they say yes, well, that's going to open up more curiosity for me. I might say, okay, well, what substances have you tried? And when was the earliest time you've tried it? Are you currently using any of these substances? How frequently are you using the substances? Have you had any kind of like fallout or problem as a function of the substance of abuse? Have you received any earlier treatment linked to substances of abuse? All of these questions pop into my head as immediate follow-ups based on an answer of yes, right? So a semi-structured interview, yeah, we might start off with the first question the same, but then we go deeper into all of the domains in accordance with where our client is and what they say. All right. Now, I talked to you that a interview can be structured or unstructured, or what I call a semi-structured interview. When you're using either an unstructured or a semi-structured interview, you're more likely to ask open-ended questions. And open-ended questions, there's not a right or wrong answer. and the person can paint whatever picture they want with open-ended questions. Whereas with structured interviews, sometimes they are manualized questionnaires. We'll talk about questionnaires. There might be Likert scales, and it really constrains what you're trying to accomplish. Another thing that you're going to take as part of the interview is something called a mental status exam. And a mental status exam is a general assessment of functioning. There are some mental status exams that focus more on cognition and orientation. So the Folstein Mini Mental Status Exam is a good example of one where it's used in many inpatient or hospital settings to determine orientation. Do you know what today's date is? Right? And we would measure day, month, year. You could get up to 3 points. Do you know where you are? So they might say, yeah, I'm in Staten Island University Hospital, right? So they will know where they are, and a whole host of other things. We might do number sequencing, right? So subtract by 7 starting with 100 as a cognitive process. But when we assess mental status, we're also assessing other parts of mental status. So I'm going to assess your appearance. Do you look appropriately dressed for the interview? So if a person is dressed, I don't know, in shorts in the winter, we might say, okay, well, that seems pretty peculiar, unless they said, yeah, I just came from the gym, forgive my attire. If a person has, I don't know, excessive amounts of makeup and they're missing one earring, we might inquire about that, right? So your appearance matters. We also listen to your speech patterns. So are you able to communicate effectively? Are you speaking in a logical and linear way? Are you speaking rapidly? So it goes like this, blah, 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 right? So is there pressured speech? So someone's speaking too rapidly or not able to take a breath, or it seems like they're not catching their breath when speaking. We pay attention to that. We pay attention to what's called mood and affect. We might ask a person, how are you feeling? And a person might say, okay, I'm feeling fine, or I'm feeling good. Well, that's the mood is what's going on inside the individual, where the affect is what the person looks like. And it is not uncommon for a person to report their internal emotion differently than how they present outward. So we would write in our mental status exam portion that mood is inconsistent with affect, right? And then we would specify client reported feeling happy, but affect appeared sad or sullen, right? And so forth. So mental status exam, now we're also, in addition to the social domains like home life, school, work, now we're tapping into what's going on internally. We also tap into suicidal and homicidal ideations, whether there is an ideation, intent, or plan. We also tap in whether there are means to complete some form of suicide or homicide. So that's the mental status exam, and it's pretty free-flowing. Now, the Folstein is a structured mental status exam, whereas many of us use our clinical interviewing to tap into the domains that I just talked to you about. So let's talk about tests, right? So we talked about interviews. Now we'll talk about tests. And there are hundreds of different tests available for a person to use. And they come in a variety of forms. projective tests, personality inventories, response inventories, psychophysiological exams, neuropsych exams, intelligence exams, and so forth. Now, I said to you that the kind of assessment you're going to do depends on the referral question. So if I had the question whether a child in school had a learning disorder, right? Would I give them a personality inventory? The answer is no. I probably would give them an IQ test. I would also give them an achievement test, and I would compare the consistency or relative inconsistency between these two. And generally speaking, a learning disability or disorder can be detected when the overall scores are about 1.5 standard deviations apart. So that's an example of how I might use intelligence testing or achievement testing. If I were trying to understand whether or not a person was competent to stand for trial, well, I'm going to use more forensically based tests. I might use some personality inventories. I might use some risk assessment tools, recidivism tools, in addition to, as I said, competency exams. So your referral question is going to inform the test you use as well. Now, I put on the bottom of the slide that there is this tremendous resource for anyone who is interested called the Mental Measurements Yearbook. And the Mental Measurements Yearbook is published, I want to say, every 2 years, and it's updated for any new instrument that is created or any updates on instruments. And it provides a solid summary of what the instrument does, and it'll talk about the relative reliability and validity of the instrument. So the Mental Measurements Yearbook is a great resource for those of us in the field as well. The American Psychological Association also created their own database in competition with the Mental Measurements Yearbook called Psych Test. And Psych Test is another one of these tools where if you're looking for an instrument for any particular referral question, you can pretty much find it. And what it will do is it'll give you the general information about the test, and many of the PDFs will also give you a copy of the instrument, assuming that it's not copyright protected. So let's talk about projective tests, right? So I said your theoretical orientation is going to impact how you administer tests and the kind of tests you use. But what is a projective test? A projective test, by definition, is when you present some ambiguous stimulus, and it's by design. You're doing this on purpose so that a person can project out their personality. And you might follow it up with open-ended questions or instructions. And as I said, projective tests are very common with psychoanalytic or psychodynamic practitioners. And there are examples of projective tests here, like the inkblot test, the thematic apperception test, sentence completion, and drawing. So here is an example of an inkblot. Now, the Rorschach is probably the most popular inkblot, but there are others. So if I were to administer the Rorschach, well, I would be giving a series of 10 cards with ink blots on them. Some of the cards are purely black and white. Some of the cards are grayscale, and some of the cards are color, as you see on the right of this slide. And I would go through each of the 10 cards, and I would ask them, tell me what you see in this card. And then I would ask the person, show me where they see it in the card. Now, I would go through all 10 cards asking for what the person sees, and then go back a second time and say, okay, on card one, you said you saw ... Can you show me where you saw it, so that I can code it? Because the Rorschach test has a pretty sophisticated coding system. And one of the coding systems that I recommend is called the Exner coding system. And there are computerized softwares that you can plug in what the person said, where they said it, and the kind of response they gave you, and it will spit out a personality profile. Now, for the sake of demonstration and a little bit of fun, can anyone give me something they might see in here? And before you answer, I will tell you, you cannot diagnose anything from a single card. So you don't have to worry about me or your peers judging you based on your response, right? And I will say that most people see more than one thing in a card. So I might say, is there anything else you see? So is there anyone in the class who wants to tell me something they might see? Let's see, someone in the chat said they saw a crab,
Spider.
A spider, a beetle, a bug. And my assumption is that that's at the center of the page, right? And someone said they saw an eyeball. That makes sense too, right? A brain, right? There are a lot of different answers coming into the chat. The red looks like a poppy flower. So yeah. Now, none of your answers are out of the ordinary. These are actually common responses to this card. Most people see one form of a flower or another with the red, right? Most people see some kind of animal in the center. Nothing wrong with any of your answers. So I want you to know that as well. But let's say someone said, I see a Lamborghini. Well, I don't know if you can make this picture into a Lamborghini, but I can't. So we would go through the back of the manual, which will tell you what the common responses are and what's considered an atypical response. And we would write it down. And if a person gave a series of atypical responses, that would suggest perhaps their orientation or cognition was distorted. There could be some parietal lobe brain damage, perhaps, or some kind of other psychological disturbance based on how they depicted this card. But even when we use projective personality tests like the Rorschach, we don't use it exclusively. We're going to use it as part of a battery. And we're going to see if there's consistency through it. Now, I will share a story. I was doing my externship at South Beach Psychiatric Center in Staten Island. And I was given the task of giving a personality assessment to one of the residents. And this person reported they saw a vagina in all 10 cards. And they showed me where they thought they saw it and everything. And obviously, that's considered an atypical response. There is one card where it's actually considered an appropriate answer or a common answer, but the other 9 cards, it's not. And we were left with the question, well, why did they say that? Were they trying to fake the test, or did they actually have a hypersexualized view? And based on other data points, it turned out that this individual had a hypersexualized view. and they were diagnosed with histrionic personality disorder. So it all kind of came together. But the answers that were given in the chat are perfectly acceptable, common answers. Here's another exam: the thematic apperception test, or the TAT. There is a child or a children's version of this test called the CAT, Children's Apperception Test. It is slightly different, and the pictures are more tailored to children. Now, Henry Murray came up with this test, and he wanted to see how people resolve conflict. So in many cards, there's multiple people in the card. The TAT has a series of 30 cards. You do not give all 30 cards. Similar to the Rorschach test, there is a standard battery, and the standard battery is a series of 10 cards. But you might say, well, if that's the standard battery, why were there 30 cards altogether? The answer is that you can swap out some cards based on a referral question to assess that. Now, when we present a card to a person, we're going to say, I'm presenting you a card, and I would like you to create a story based on this card that has a beginning, middle, end, and a thought and a feeling that comes up. And we would invite them to share a story. And we're going to write verbatim what they said. So word for word, what they said. Because that's going to be important when we code this later, because we need to make sure that there was a beginning, middle, end. We need to be able to identify patterns of thoughts or patterns of emotions, right? Because if you see, the first word is thematic apperception test. So we're looking for themes. So once again, a single card is not going to be predictive of personality, similar to the Rorschach. And the TAT alone is not sufficient to do a personality assessment. So I'd like to invite someone to share a story based on this card that has a beginning, middle, end, a thought, and a feeling. And if you could, instead of using the chat, because this will be a lot harder, if you could unmute yourself or raise your hand, and I can call on you to do so. So is there anyone who would like to share a story based on this card? Going once, going twice, going 3 times, and we're done. Now, I will tell you, the common stories that come up are linked to parent-child conflict. And that kind of makes sense to you, right? Because there is an older figure and a younger figure. The younger figure is by design a little bit more ambiguous in their gender, but there is a slightly higher proportion of people who report the younger person in the picture as female. So it's oftentimes mother-daughter conflict that comes out of this. You also have, some themes of Sleeping Beauty, right, with the apple, right? So the older woman is sometimes depicted as a witch. And then you have another common theme that people talk about, reminiscing about one's youth. So sometimes people tell the story through the eyes of the older woman, saying that she's looking back to, it's almost like a flashback to her youth. So these are common responses. And someone said they thought it looked like a creepy nun. Possibly, yeah. So if you gave a story around that, that would be a pretty interesting story. Now, you might say, what is the benefit of the beginning, middle, and end? Usually, the conflict is based on the story with the beginning and the middle. The end of the story gives you the insight of conflict resolution. And it's a really cool test, right? So there is no objective right or wrong answer. So your colleague who put in the chat that it looks like a creepy nun, okay, that's fine. There's no right or wrong answer here. Also could look like a stalker, right? Someone else said. So, but yeah, the story itself, we care about how you string stories together and how you resolve conflict. Now, the thought and the feeling, that part of the TAT also should make a lot of sense to you, because we're looking for patterns of thoughts, patterns of emotions. We code your emotions. Let's say out of the 10 cards we give you, 8 out of the 10 cards depict some form of a negative emotion. That would be important to put in the assessment, because it could reflect either some kind of depressed mood or dysregulated mood, right? And it's a data point. Just like every other instrument we're going to use, it's a data point to inform other parts of our assessment. There are other things that people do. So there's a sentence completion task. So you might give a sheet of paper and you ask a person to complete the sentence. So I wish ... So as students, you might say, I wish the class was over. Now, I don't think that's the case, but you could fill it in any way you want. My father ... And what you're doing is you're inviting the person to share what's going on internally, and you could look a little bit more into their world. We also have things like picture drawing tasks. So like draw a person. When we ask you to draw a person and then draw a person of the opposite sex, that's designed to give us some kind of view of the self. And when you draw a picture, we believe that you're drawing yourself. Now, there is a more sophisticated set of drawings, the house tree person test. That happens. A lot of police departments use that as a projective test. So the house is more of a depiction of your early childhood and your home life. Your tree is more of your developmental history and your extended friendships and relationships. And the person is your view of yourself, right? So, and then we interpret size, location, etc. So let's say a person drew a picture of an individual very small. They have an 8.5 by 11 piece of paper, and then they draw this person really, really small and perhaps to the corner of the page. Well, we might say that, hey, this could indicate poor self-esteem, right? Because they view themselves very small and they view themselves very distant, right? Because most people are going to use the vast majority of the paper and they're going to draw themselves as a reasonable size. Now, notice we're not asking a person, draw a picture of yourself. We just say, draw a person, and we infer that this is how you view yourself, right? It's a pretty cool tactic. If a person drew a house, I had this as an example. A person drew a house on the top of a hill, kind of hanging at the top, angled outward. And this person had previous suicide attempts and was recently suicidal. Well, the interpretation of that picture is perhaps that's symbolic of thoughts of suicide, right? And so forth. Now, these are our projective tests. Before I move on, I will say the strengths of projective tests is that they're intentionally ambiguous so we can tap into the recesses of your personality. There is no right or wrong answer objectively. So those are some of the real benefits. The criticisms of projective tests are in terms of whether my interpretation would be consistent with the next clinician's. So there are real questions about reliability and validity of projective tests used in isolation. So let's talk about other personality inventories. Well, there's a whole host of personality inventories, but you'll probably be most familiar with the MMPI, the Minnesota Multiphasic Personality Inventory, which has over 500 questions that are true or false, and it taps into multiple clinical areas. And I think it's very important to emphasize when we use the word inventory, it has to tap into multiple domains, right? Now, in addition, so there are 10 clinical scales as it relates to the MMPI. In addition to the clinical scales, we also measure the validity of your answers. And the MMPI is a really cool instrument because we can tap into a bias for true, right? So there's a true response subscale. So if a person says true excessively, that could be elevated or flagged. We also see that there are several items that ask the same or very similar questions. So we have a variable response, which means that the person is inconsistent in their answers. We have a way of detecting whether a person is faking good or exaggerating their symptoms and faking bad. We have a way of detecting defensiveness. We have a way of detecting boredom. So the MMPI is a really powerful instrument. And as a function of giving it, first we look at the validity scales. And if it's a valid assessment, then we look at what's called the 2-point code. Now, I'll give you, this is an example of a profile. And if I were to say, well, what's the 2-point code? The 2-point code would be this individual's a 2-7. Now, how do I know this is the 2-point code for this individual is a 2-7? Well, if you look at the two highest scores, the peaks are 2 and 7. So this person would likely present as an individual with major depressive disorder and some OCD, right? So, and I'll go through it. You'll notice that we have the list of scales, the 10 clinical scales, but most of us, when we write the reports, we don't use the labels because labels can be stigmatizing. We say scale 1, scale 2, all the way to scale 10 or 0, right? And when you have 2 standard deviations of elevation, we consider that clinically significant. Now, there are other people who use 65 as a threshold, not 70. And it makes sense based on what I said about 1.5 standard deviations. If the t-score is supposed to be 50 and a standard deviation is 10, the difference between 65 and 50 is 15. So that's 1.5 standard deviations. So some people use 70, some people use 65 as their marker of a clinically elevated scale. And from this, notice how I said this person likely would meet the criteria for major depressive disorder and OCD or obsessive compulsive disorder. Well, that is revealed in this profile. Now, psychasthenia which is scale 7, or the PT scale, right? That is OCD. That's a fancy way for saying OCD. But I also said we use the scale number, not the label, because let's look at scale 4. Scale 4 is referred to as psychopathic deviance. And if we're looking at a 2-point code, scale 4 in isolation would not indicate a person who has antisocial personality disorder. There have to be other factors elevated for that diagnosis. But so what does this deviance really reflect? It could reflect some criminality. It could reflect some moral or ethical deficits, but it could also reflect a person who beats to their own drum, who is kind of eccentric and doesn't have a diagnosis. And I say that because imagine you told a person your scale for psychopathic deviance was elevated, and all you meant was that they beat to their own drum or they're eccentric. That wouldn't be nice to use those words. So that's why we would say scale 4 in that case. So I said we have the ability to detect accuracy or validity. So we have the L scale, which measures faking good. And you might ask yourself, well, why would a person want to fake good? The answer is pretty simple. People fake good when their goal is for social approval. So the MMPI is also used as a predictor of suitability for the police force, right? So you might exaggerate how ethical or how good you are because you want to present yourself in an overly positive way. Faking bad, you might also say, hey, that doesn't make sense either. Why would a person want to make themselves look worse than they really are? Well, if a person is trying to avoid something like legal liability or responsibility, a person might fake that they're worse off. Or in other settings, if there's some kind of damages case, a person might want to present themselves as more physically or emotionally damaged because they'll get a higher payout. The lawsuit will get more money. So sometimes people fake bad as well. And then there are people who are very sensitive to criticism. So we have 30 items that are designed to tap into defensiveness. So we have our validity scales. I also said we have the ability to measure boredom. So there's something called the Backpage Infrequency Scale that can detect whether, as the test went on from the beginning or the first half of the test to the second half of the test, whether you started to answer in an inconsistent or unreliable way. So we can detect if a person got bored and just started randomly responding. We also pay attention to how many items you leave blank. In principle, if a person leaves 10 items blank, they're supposed to invalidate the test. Most of us don't do that. Before we consider invalidating a test, we look at the questions and we want to know if there's a pattern in the kinds of questions that a person left blank. Because sometimes when a person says cannot say or left blank, there's a reason why they're doing that. And it could be that there's some kind of trauma. So let's say all 10 questions had to do with early childhood development. Well, that could reveal something if they intentionally left those items blank. That's the MMPI. Now, I will tell you that the MMPI is not the only broad personality inventory. We have the PAI, we have the MCMI, and I know I'm throwing out a bunch of acronyms or letters, but one of the biggest criticisms of the MMPI is it doesn't have the same strength of identifying personality disorders as, let's say, the Milan Clinical Multi-Axial Inventory. So the MCMI does a much better job at detecting personality disorders. The PAI does a better job at getting spectrum-based responses, because the MMPI was true and false, right? So the PAI is from strongly agree to strongly disagree, and it's a shorter test as well. So there are reasons why we might use a different personality inventory. Now, personality inventories are broad, covering many clinical domains. We also have a response inventory or response questionnaire, and that's focusing on one area of functioning. So something like the Beck Depression Inventory. So the Beck Depression Inventory is only measuring depression, whereas the MMPI measured depression, it measured mania, so bipolar disorder, it measured OCD, it measured a whole bunch of other things. The BDI, or Beck Depression Inventory, is only measuring depression. And response inventories are usually based on self-report, and you can tap into one's emotions, one's thoughts or cognitions, and one's social skills. Now, one of the problems with self-report is the social desirability we talked about. So we have the risk of someone lying, right? As I said, on the MMPI, we wanted to make sure that the person wasn't faking good or faking bad or being overly defensive. But response inventories have that same problem of honesty. We also have psychophysiological tests. So now we're linking your bodily response or physiological response to some kind of psychological condition. So your heart rate is a good indicator of sympathetic arousal. So if you have a significantly elevated heart rate, that could indicate levels of anxiety or stress-related disorders. Blood pressure is another measure we use. Body temperature, the galvanic skin response, which is sweat, muscle tension, all of these are data points that could reflect a psychological disorder. Now, you probably have heard of the polygraph or the lie detector test, and the lie detector test capitalizes on both muscle contraction and sweating. So that's part of how we detect some kind of problem. Now, there are other tests that we use, right? So you might see an EEG, electroencephalogram, which is designed to measure the firing of neurons in the brain. Well, that would be useful at detecting sleep-related disorders and seizures, right? So an EEG is useful for that. A CAT scan or an MRI, these are still images. So they're static images, which give you a picture of the brain or parts of the brain. And we can detect all kinds of structural abnormalities based on a CT scan or an MRI. So we can detect Alzheimer's due to some kind of atrophy to the hippocampus or the amygdala, and so forth. So we can use CT scans, we can use MRIs as still pictures. Now, the PET scan and the fMRI, these are dynamic tests, which means that you're measuring the brain's functioning while a person is doing a task. So a PET scan is looking at radioactive dye and the glowing of various parts of the brain, whereas an fMRI is looking at blood flow to different parts of the brain. So there are a lot of instruments. So now with the PET scan and an fMRI, we can detect some form of physiological pathology. So before I go to neuropsych tests, I will also say a criticism of the physiological or neurological tests is that they oftentimes use equipment that are anxiety provoking. So you can induce anxiety when a person's getting a CAT scan. You can induce anxiety when a person's doing an EEG. And if you're trying to get a valid measure, it's problematic. The nice thing about the psychophysiological methods or the neurological test is that we're able to link the brain to your psychological functioning. We're also able to tap into segments of the population that cannot communicate. So neurological or psychophysiological tests you can use with infants, even if a person is nonverbal or preverbal. We also have something called neuropsychological tests. And again, neuropsychological tests come in many forms. So it could be your executive functioning, decision-making, planning. It could be your spatial or perceptual awareness. It could be motor functioning and so forth. And what you're looking at here is a picture of a person who has brain damage, right? And we gave them the Bender visual motor gestalt test, or what we just call the Bender. And we give them a series of cards and we ask them to do a direct copy of whatever they see on the card. And what happens is if there is some spatial related brain damage, you're going to see problems like at the top where the diamond is not fully closed. You're going to see rotations. You're going to see conversions, omissions, extensions beyond what the picture actually was. So if you were guessing, you would suggest that this person has deficits in spatial reasoning, right? And perhaps the parietal lobe is damaged here. Now, the Bender, there is a second one which also taps into memory, where you ask people to reproduce from memory some of the shapes as well. So we have a direct copy and then a recall of the shapes. So the Bender is a good example of just one neuropsych test. Then we have intelligence tests. Intelligence tests measure your intellectual ability. Today, they tap into both verbal and nonverbal skills typically. And when we talk about intelligence, you're going to get what's called an IQ score, which is your general intelligence quotient. And we consider IQ to be 100, that's average, with a standard deviation of 15. Therefore, if a person is 2 standard deviations above or below 100, we would say that they have a significantly different or atypical intelligence. So let's take a person who has an IQ of 130 or above. Well, we colloquially refer to this person as a genius, right? Their IQ is significantly higher than average. If a person has an IQ 2 standard deviations below the mean, that would be an IQ of 70. So an IQ of 70 or below, coupled with deficits in adaptive functioning, would indicate some kind of intellectual disability, what used to be referred to as mental retardation. So an intellectual disability or intellectual developmental disorder, right? That's the language we're using today. Now, there are many different intelligence tests on the market. The most popular ones today are the Wechsler tests, although there's the Stanford Binet test, which is another really good one. There's the Bailey scales for infant intelligence. There's the Woodcock-Johnson as another one that's really, really popular and good. But let's talk about the Wechsler test. So the Wechsler test happened in response to the Stanford-Binet. And I'm not going to go into the early history of intelligence testing and how Alfred Binet formulated the test and how it was transformed. But David Wechsler basically felt that we can do a better job at assessing intelligence across the age spectrum. And one of the first things he did was divide the intelligence tests into 3 separate ones: the WIPSI, WISC, and WACE. And you will see that there are different age brackets where a person can take a test. So the WIPSI does a really good job, and you can assess intelligence at 2.5 years old all the way up to 7 years old. The WISC is from 6 years old to 16 years old, or 16 years, 11 months to be more specific. And then we have the WACE, which is 16 years to 90, or 90 years, 11 months. So we have a broad range of instruments in the Wechsler test family for different age brackets. Now, what happens if you have a person that's on the cutoff, right? Let's say you have a 6-year-old or a 16-year-old. Which intelligence test would you give them? The answer is it doesn't matter. If you have a 6-year-old, you could give the WIPSI or the WISC, and you're going to get roughly the same IQ score. So it isn't just about accumulated knowledge. IQ is aptitude or potential. So a 6-year-old taking the WIPSI would get roughly the same IQ as if they took the WISC, because these are standardized tests. And when I say standardized, that means the administration of the test is standardized. So we say the same prompts, we give the same questions, but we also rely on a standardization sample to create the norms. So we take thousands of kids and we figure out what the average response at a given age bracket should be. So whether you gave the WIPSI or the WISC, the common response at the age bracket is going to be where it's going to be. Same thing if you have a 16-year-old, you could give the WISC or the WACE, and it really wouldn't matter because you're going to get roughly the same result. Now, the Wechsler tests also have performance elements to them. And when we say performance, these are referred to as nonverbal scores. We have verbal aspects of intelligence, and we have composite scores or general indices of performance. So intelligence testing is far more sophisticated than where we started. Now, a big criticism of intelligence before I move to clinical observations is that intelligence testing still does have some biases involved in it. So there are cultural biases with the verbal elements. So there are people who have pushed for nonverbal intelligence scales, and we have those. We have the test of nonverbal intelligence and many others. Raven's progressive matrices is another one in an intelligence test that doesn't require verbal responses. So if you have a nonverbal child or you're worried about cultural biases, this could be useful. We also have, so I talked to you about the interview process. I talked to you about the testing process. Now let's talk about the observation, which is the third general section of assessment. So we can observe behavior through naturalistic, analog, or self-monitoring ways. A naturalistic observation is where you're observing a child perform in a real world environment. Or it doesn't actually have to be a child, it can be an adult as well. But let's say we're talking about a child, we might observe a child in a classroom. Well, a classroom is a natural environment, a real world environment. We might sit at the back of the classroom and see how the child interacts with other classmates. And that would be a naturalistic observation. It is designed to happen in the real world so that you can get more generalizable or representative responses. So we can focus on parent-child, teacher-student, child-child interactions. We also can have what's called a participant observer, where the clinician interacts with the child directly versus watching the child from afar. One of the criticisms of the participant observer is the influence of the person observing could alter the behavior versus watching from afar, they're going to behave more naturally. So that's naturalistic. Then we have something called an analog observation. An analog observation is observing someone in a more artificial environment. So if I was a clinical researcher, I might have a family come into my lab, and I might sit them in a circle and leave the room and just observe how they interact with one another from afar. Or I could ask them to do a task in the lab. Or I can have one-way mirrors, right? If you're a researcher, you might, once again, not want the person to know you're watching them. But the difference between a naturalistic and an analog observation is that the analog observation occurs in a more artificial environment. You can control for some biases with the artificial environment, but the generalizability you get from a naturalistic observation is reduced with an analog observation. And then last but not least, we have something called self-monitoring. And self-monitoring is we invite a person to observe their own actions. So we might ask a person to engage in journaling or writing a log. Remember the person with panic disorder. I might have them write the date of the panic attack, what they were doing before the panic attack, how long the panic attack lasted, and what they did to resolve the panic attack. And that is a way of logging panic disorder, but getting a sense as to what is the frequency of panic attacks, what are your triggers of panic attacks, what are your coping strategies that work, and so forth. So self-monitoring can be done through journaling. We might have a thought record if we're working on some cognitive restructuring task, or there is a form of self-monitoring where we either text or page a person and say, okay, can you write what you're doing now? The problem with self-monitoring is that people are inconsistent with writing in what they were doing or observing their own actions, and people filter their observations. So that's clinical observations. Now I'm going to stop the recording here, but as you can see, we have ways of doing assessment that come in the form of interviewing, come in the form of psychological assessment or testing, and through observation, both direct or indirect observation. Once we get all of this information, we're able to move to the concept of a diagnosis. But let me stop here for the moment.